My name is Sarah Durfee. I'm an assistant professor of radiology at Harvard Medical School and an attending radiologist at Brigham and Women's Hospital in Boston, Massachusetts, and I will be speaking on fetal genitourinary abnormalities. I have no financial disclosures. Genitourinary abnormalities comprise about 20% of all congenital structural anomalies, and about the majority of these congenital anomalies in the GU tract can be detected prenatally in approximately 80 to 85% of cases. It's important to make the diagnosis prenatally because this will permit antenatal counseling as well as permit prompt postnatal evaluation and treatment, thereby avoiding therapeutic delays that may result in loss of renal function potentially. These anomalies may be isolated or can be seen with other abnormalities, particularly chromosomal abnormalities can be seen in 12% of these fetuses. And unlike other abnormalities, genitourinary abnormalities may in fact lead to other deformities, which we'll discuss shortly. AIUM guidelines state that all second and third trimester ultrasounds should include images of the kidneys or the renal fossa. And we can start to see the kidneys on prenatal ultrasound at about 9 weeks gestation transvaginally and 12 to 13 weeks gestation transabdominally. And it's not until the around 20th week gestation that you begin to see the nice corticomedullary differentiation that we can see here in this kidney of a fetus of about 20 weeks gestation. When we evaluate the fetal kidneys, we need to assess for the presence of two kidneys and the location in the renal fossa, and sometimes this view here with color Doppler, a coronal view of the aorta, can nicely show you the renal arteries on both sides, which can confirm the presence of a kidney on either side of the fetus, which sometimes the kidneys may be somewhat difficult to assess since they are only slightly echogenic and their margins can be somewhat ill-defined. We can look at the size of the fetal kidneys, their echogenicity, and also look for cysts or hydronephrosis. We don't normally see the fetal ureters because the caliber of the ureter is usually less than about 1 millimeter. But as the ureters dilate to 2 to 3 millimeters, as you can see here, with fluid within the ureter, we start to be able to see the mildly dilated ureter. AIUM guidelines also state we should be able to see the bladder within the pelvis, and certainly even during the first look examination at the end of the first trimester, we can see fluid within the bladder within the pelvis. The umbilical arteries will splay around the bladder in some cases, and we can confirm that this is actually the bladder and not a pelvic cyst perhaps, because the bladder will fill and empty over time, changing size. Now, it's important to understand that the amniotic fluid is virtually all generated from amniotic fluid by about 18 weeks gestation, so a normal amount of amniotic fluid confirms that at least one of the kidneys is functioning properly, and there's a patent conduit from the kidney to the bladder and then out into the amniotic fluid, and an overall good prognosis for the fetus. However, if the amniotic fluid is diminished and there is severe prolonged oligohydramnios, which can occur if the kidneys are not functioning properly or if there is severe obstruction bilaterally, this in turn can lead to other abnormalities within the fetus, including pulmonary hypoplasia, which is important because this can be lethal, as well as facial abnormalities, including low-set ears or a flattened nose, and limb positional abnormalities, including club feet and other positional abnormalities. Now, when we look at the fetal kidneys, let's first talk about whether the kidneys are present and if they're present in the proper location. So what do we think about when we can't see the kidney in the expected location of the renal fossa? Well, about half the time this is due to the fact that the kidney developed normally, but is in a location that is not within the renal fossa, and this is renal ectopia. The most common cause of renal ectopia is a pelvic kidney, but horseshoe kidney or cross-fused ectopia can also be seen with renal ectopia. Half of the time, however, when we don't see a kidney within the renal fossa, this is because the kidney failed to develop at all, and this can be unilateral or bilateral. Now, sometimes it's hard to tell whether the kidney is present or absent within the renal fossa, and there is a sign, the lying down adrenal sign, which was described way back in 1992, to confirm the absence of a kidney within the renal fossa. The normal adrenal has an inverted Y shape, and when there is no kidney in the renal fossa, this adrenal gland can stretch out into the renal fossa, which is unoccupied, and look like a long linear hypoechoic structure sort of adjacent to the spine within the renal fossa. And this is the lying down adrenal sign, and it implies that there is no kidney within the renal fossa. Now, when we talk about renal ectopia, again, the most common cause is a pelvic kidney. And this occurs when the kidney develops normally but never ascends normally into the renal fossa during development. And what you'll see in a transverse view here in the abdomen, we have a normal left kidney with a little bit of fluid within the renal pelvis, and there is no kidney identified in the right renal fossa. And this, of course, could be confirmed in a parasagittal view with the lying down adrenal sign, but instead we looked in the pelvis, and you can see it's a little bit tough to see this sort of transverse positioned kidney sitting above the fetal bladder, low down within the fetal pelvis. This is a pelvic kidney. Now, pelvic kidneys can be hard to see. That mildly echogenic kidney can be obscured by adjacent bowel within the fetus. And in this particular case, prenatally, a normal left kidney was seen, and there was nothing in the right renal fossa, and no pelvic kidney or other kidney could be identified on the right. And this was thought to be unilateral renal agenesis. However, the baby was born and was brought down for a renal ultrasound, and you can see nicely in the right upper quadrant a nice lying down adrenal sign, which looks so pretty because this is taken postnatally. And when we searched even more, we looked down in the pelvis, and you can see in the right lower quadrant a pelvic kidney, which was not able to be identified prenatally. Now, crossed renal ectopia is a rare cause of renal ectopia, and this occurs when one kidney ascends normally and the second kidney on the other side, instead of ascending normally, crosses over to the contralateral side and ascends beneath the normally positioned kidney, and the upper pole of that malpositioned kidney fuses with the lower pole of the normally positioned kidney. And so what you have is one enlarged bilobe kidney representing the two kidneys attached together. Here's the normally positioned kidney, and then the second crossed fused kidney below it with nothing on the other side. And here we have another case of crossed renal ectopia. This case was not picked up at 18 weeks gestation. There was thought to be normal kidneys. It was difficult to say, but there was a two-vessel cord, and two-vessel cords can often be seen in the presence of genitourinary abnormalities. The patient was brought back at 26 weeks for a growth scan, and when you look in the right renal fossa, there's the lying down adrenal sign. There is no right kidney within the renal fossa. But instead, if you look on the left, you see an extra large kidney with this bilobed appearance representing the cross-fused renal ectopia on the other side, on the left side in this case. Now, horseshoe kidney occurs when both kidneys ascend, but only ascend partially, and the lower poles of both kidneys sort of rotate medially and fuse across the midline anterior to the aorta and the fetal spine. And these horseshoe kidneys can be associated with other abnormalities, including a duplex collecting system and reflux. And in this particular case, you can see the horseshoe kidney here. We're lower in the abdomen than the normally positioned kidneys because we have here a picture, image of the bladder in this same cross section. You can see the kidney crossing anterior to the aorta and the spine behind. And in this particular case, again, seen with a two-vessel cord, seen associated with genitourinary anomalies often, and in this particular case, a VSD. Now, sometimes it's not that the kidney failed to ascend properly, but in fact never developed, and this is renal agenesis. And when this is unilateral, the patient the fetus can have a normal life expectancy after birth. But you will see, just like in pelvic kidney, you'll see an absent renal, an empty renal fossa like we see here, nothing here on the left, a normal right kidney on the other side. You can confirm this with a lying down adrenal sign in the empty renal fossa, and sometimes the contralateral kidney will be large as it compensates for the absence of the other kidney. And we can see here a normal kidney on one side, on the other side the lying down adrenal sign. No kidney was seen in the pelvis. This was unilateral renal agenesis. Now, what happens if the kidneys don't develop on either side and you have bilateral renal agenesis? Well, this is a lethal abnormality, unfortunately. You're not going to be seeing the kidneys in the renal fossa. When we look here in this particular case, we see these little hypoechoic areas adjacent to the spine, which actually are the somewhat bunched up adrenal glands, not the kidneys. Because there's no urine being formed, because there's no kidneys, you won't be able to see a bladder. And there will be severe oligohydramnios because no fetal urination is occurring. And so it's very difficult in these cases to make the diagnosis of absent kidneys because you don't have that nice acoustic window of the amniotic fluid which normally surrounds the fetus. We can see here images of the fetal pelvis, and you're not able to see the bladder within the pelvis as the umbilical arteries swing around around the area where the bladder should be. Here's another case of bilateral renal agenesis. This was di twins, and the one twin was normal, and here with the posterior placenta we have the second twin at 14 weeks, and you can see the amount of amniotic fluid is markedly decreased. Bilateral renal agenesis was suspected. We did this coronal aorta view, and we couldn't see any renal arteries on either side. There was no fluid visualized in the urinary bladder. Bilateral renal agenesis was suspected, and the patient was brought back 2 weeks later, and you could see, again, no kidneys visualized within the renal fossa, no fluid within the bladder, very, very little amniotic fluid at this point, in a spine abnormality in this lethal abnormality for this fetus. Now, moving on to echogenicity within the kidneys, there are many, many causes of increased echogenic kidneys. Some of these are inherited diseases, some are acquired, and you can see in the list I've broken them down into kidneys which are echogenic and increased in size, and those that are echogenic and normal size. And when we talk about increased size echogenic kidneys, some of the things we would consider would be inherited polycystic kidney disease, some genetic syndromes, some of which I'll show you, some acquired things like a CMV infection, renal vein thrombosis, as well as chromosomal abnormalities. And the normal-sized echogenic kidneys include normal kidneys as well as obstructive cystic dysplasia. Now, here's an example of enlarged echogenic kidneys. Here we have a transverse view of the fetal abdomen with these large kidneys sort of coming way in front of the fetal spine. And this was seen in association with holoprosencephaly in a fetus with trisomy 13. And here's a kidney. It's very remarkable how large and echogenic these kidneys are. You can see in this fetal abdomen how big these kidneys are, measuring over 5 centimeters. That's larger than a kidney would be in a full-term baby at birth. And when you did a profile view of the fetus, you can see that here's the upper lip and the lower lip, and there's this large tongue which is sticking out and could never retract into the mouth, and this is because this tongue is enlarged. And this is a fetus with macroglossia associated with these large echogenic kidneys in a fetus with Beckwith-Wiedemann syndrome. Renal vein thrombosis is not common, but you can see in large echogenic kidneys. This is often seen with coagulation disorders leading to renal vein thrombosis. It can be seen with sepsis or possibly maternal diabetes, and you can see these kidneys, and these characteristically have these more linear echogenicities within the kidney, but they can be acutely more swollen in a more acute situation. Moving on to renal cystic disease, again, these are a group of inherited and acquired and developmental disorders, including multicystic dysplastic kidney, the inherited polycystic kidney disease, as well as renal cysts and renal dysplasia. And the most commonly seen cystic disease of the fetus would be multicystic dysplastic kidney, and this is in fact the most common abdominal mass that is seen within a neonate. And this actually develops very early in gestation, before 10 weeks, and it occurs when there is complete obstruction or atresia at the renal pelvis very early on, and this complete obstruction leads to severe dysplastic changes within the fetal kidney, which results in replacement of the normal renal parenchyma with these multiple non-communicating cysts of varying sizes and shapes. And fortunately, the other kidney is normal, will generate urine, and there will be a normal amount of amniotic fluid. In some cases, particularly UPJ can be seen in the contralateral kidney. So you need to look, when you see multicystic dysplastic kidney, you need to look at the other kidney for contralateral abnormalities. And here's an example of a multicystic dysplastic kidney. You can see these cysts of multiple shapes and sizes filling the renal fossa. There is no normal renal parenchyma within this kidney. This is a non-functioning kidney. And here's another case. We can see sort of the downside, a multicystic dysplastic kidney. None of these cysts communicate with each other. This is not hydronephrosis. But on the upside, in the contralateral kidney, there's hydronephrosis here. There's dilatation of the ureter as well in a patient with multicystic dysplastic kidney on the left, as well as a UVJ obstruction on the right. It would be very important in this particular case to look carefully at the amniotic fluid volume to make sure that enough urine is being generated and filling the amniotic cavity. Now, autosomal recessive polycystic kidney disease. In this inherited disorder, there is cystic dilatation of the renal tubules as well as hepatic fibrosis. And the degree of renal involvement is often inversely proportionate to the degree of liver involvement. And depending on how much involvement there is within the kidneys will determine what the prognosis is for the fetus or neonate. And the earlier that you see manifestations of autosomal recessive polycystic kidney disease, it's usually the kidneys that are involved first. So when we're seeing the manifestations within the in utero, within the fetus, it's usually because there is the kidneys are involved, and this unfortunately has a poor prognosis for the fetus. And what does this look like on ultrasound? While there is cystic dilatation of the tubules, we actually do not see these cysts prenatally. What we do see are these very, very large echogenic kidneys. And the echogenicity are the interfaces between these tiny little cysts within the tubules. And you can see how large the cysts are in this abdomen, basically filling the entire abdominal cavity. These kidneys here measure over 8 centimeters, if you can believe. Almost the size of an adult kidney. Because these kidneys are not functioning well, they are completely replaced by these dilatation of the tubules. You may not see any fluid within the bladder, and these fetuses will have severe oligohydramnios and will have pulmonary hypoplasia, unfortunately, at birth. And here's a case where it didn't look quite so bad at the time of the survey. These kidneys are not particularly large, but they are extremely echogenic. And already you can see that the amount of amniotic fluid is decreased. There's oligohydramnios. But at birth in the NICU, we went up to scan this fetus who was having difficulty breathing, and here are these kidneys. These kidneys are massive. These were 12 centimeters each, the size of an adult kidney. On both sides, you can see this is what the autosomal recessive polycystic kidney disease would look at birth, and this neonate did not survive. Autosomal dominant polycystic renal disease, we usually think of this as a disease of young adulthood, and the patients present with cysts, hypertension, and sometimes renal failure. But occasionally, you can see manifestations of this disease prenatally on fetal prenatal ultrasound. And like autosomal recessive polycystic renal disease, these patients, these fetuses will have enlarged echogenic kidneys. But there isn't as much damage to the kidneys in that these kidneys are able to produce urine, resulting in normal amniotic fluid and fluid within the bladder. You can see here we have these large echogenic kidneys in this fetus that had autosomal dominant polycystic kidney disease. There is a little bit of fluid and urine within the bladder in this particular case. And this fetus had a mother and a grandfather, both with autosomal dominant polycystic kidney disease. Meckel-Gruber syndrome is another inherited syndrome which is autosomal recessive, which results in enlarged echogenic kidneys and cystic kidneys. You can see these large, again, cystic kidneys filling the entire abdomen of this fetus. And when you see this, not only are we going to think of polycystic kidney disease, but these syndromes, which can be associated with other anomalies, including encephalocele, polydactyly, and cardiac abnormalities. And you can see here these echogenic kidneys, not quite as large as the last case, with polydactyly within the hand, 6 fingers, as well as 6 toes. And another case with this one had much larger cystic kidneys filling the abdomen. Here's the fetal abdomen. And in this particular case, you can see a defect within the posterior skull, an encephalocele, posterior encephalocele, scooting out the back of the fetal head. The images, as you can see, are not as easy to see things as they are sometimes, and this is because of the oligohydramnios present in this case because of the renal disease. Now, what about renal cysts? These occasionally can be seen. These look like cysts in adults as well as a unilocular round or oval anechoic fluid-filled lesion. They're usually seen within the periphery of the kidney in the region of the renal cortex. And when you see a renal cyst, it could be an isolated renal cyst in which there is usually a good prognosis. They often will regress on their own. But you need to think of 2 other possibilities on your differential, including hydronephrosis of the upper pulmonoidy and a duplex renal collecting system, or as an early sign of renal dysplasia. Now, renal dysplasia is an important diagnosis to know about and to think about, and this occurs when there is long-standing renal obstruction, and the back pressure of this obstruction leads to dysplasia of the surrounding parenchyma. And when you get dysplasia within the surrounding parenchyma, this manifests on ultrasound as increased echogenicity of the cortex as well as multiple peripheral cortical cysts. And once you get these changes of renal cystic dysplasia from an underlying obstruction, this has a poor prognostic sign for function of this kidney. Usually the kidney will no longer function, and this is irreversible. And you may or may not see the underlying hydronephrosis because if there is poor absent renal function, there's no longer urine being generating to distend the collecting system proximal to the obstruction. You can see here a case of bilateral renal cystic dysplasia. Here is the transverse view of the abdomen with these cystic structures within the renal fossa representing bilateral renal cystic dysplasia from long-standing obstruction early on. You can see the severe oligohydramnios in association with this bilateral renal cystic dysplasia and lethal prognosis. Now we'll begin to talk about hydronephrosis or dilatation. This is a common abnormality that we will see frequently if we're doing fetal ultrasound. And if you're going to look for hydronephrosis, you need to measure the renal pelvis in a transverse view of the fetal abdomen. You're going to measure the renal pelvis in an AP diameter, the right and the left side. You're going to report this measurement. This is going to be important. But we're also going to look in a sagittal plane, looking through the kidney for areas where the calyces might be dilated as well. We're going to look at the cortex too to make sure that there aren't any changes of renal cystic dysplasia, including increased echogenicity like we see here, or maybe some cysts that might be associated with that. Are the ureters dilated? Is the bladder involved? Is the degree of amniotic fluid normal or compromised due to the obstruction? And because there is an association with trisomy 21 and mild dilatation of the renal pelvis, you might want to be sure that there are no other findings on the scan to suggest trisomy 21. Now, there was a consensus conference. I urge you to look at this reference in the Journal of Pediatric Urology from 2014, a consensus panel which included some radiologists as well as the Society of Fetal Urology, which has drafted nomenclature and guidelines as to when to call possible hydronephrosis or hydronephrosis prenatally as well as postnatally. And their criteria are broken down into the second and third trimester. You can see in the second trimester, 4 to 6 millimeters AP diameter of the renal pelvis is considered possible hydronephrosis, but if it's greater than or equal to 7 millimeters, it's considered abnormal. In the third trimester, you get a little bit more leeway. 7 to 9.9 millimeters would be possibly hydronephrosis, and greater than 10 would be considered abnormal. Certainly, if you see caliectasis, abnormal renal parenchyma, dilated ureters, or an abnormal bladder, regardless of the measurement, this would be considered to be abnormal. Now, what are the cause of antenatal hydronephrosis? Sometimes, in many cases, this will be transient. So if you follow this prenatally and also postnatally, a lot of hydronephrosis that we see prenatally will resolve. The most common cause of antenatal hydronephrosis from a pathologic standpoint would be UPJ obstruction, and then down the line with reflux, megaureter, UVJ obstruction, valves, as well as the duplicated renal collecting system. Now, ureteropelvic junction obstruction is the most common cause of neonatal hydronephrosis, and this occurs when there's abnormal musculature within the proximal ureter, which leads to abnormal bolus formation and propulsion of urine from the renal pelvis down into the ureter. Like most genitourinary abnormalities, more commonly seen in males than females, and it's not a mechanical obstruction but a functional obstruction. It's usually unilateral, but you can see contralateral renal anomalies in 25% of cases. Now here we can see UPJ obstruction. We have this dilatation in the renal pelvis. There was no dilatation of the ureter. The bladder was fine. But in this particular case, we see the dilatation, but the kidney is small and echogenic. And when you look at the renal cortex, you already see little renal cysts of renal cystic dysplasia from this long-standing obstruction, and this kidney would be poorly functioning. And in response, the other kidney has enlarged, is hypertrophied, to take on the responsibility and the function of 2 kidneys instead of 1. Now, reflux can be seen on prenatal ultrasound as well, and you can see this is hydronephrosis and hydroureter. And it's interesting to watch because as you look at the collecting system over time, you'll see the renal pelvis and the ureters get bigger and smaller as the retrograde flow of urine from the bladder up into the ureters and renal pelvis goes sort of back and forth. This reflux usually occurs when there's an abnormal relationship between the distal ureter extending, tunneling through the bladder wall to the UVJ. Primary megaureter occurs when there is an aperistaltic segment within the distal ureter. So again, this is a functional obstruction, not a mechanical obstruction to flow of urine from the kidneys into the bladder. Also seen more commonly in males than females. And on ultrasound, you can see hydronephrosis, dilatation of the renal pelvic calyceal system, and also dilatation of the ureter. So without this intermittent waxing and waning of the hydronephrosis, primary megaureter is indistinguishable from reflux. And importantly, if these are followed, particularly if the dilatation is not severe, the majority of these neonates after birth this will over time spontaneously resolve. Now, renal duplication occurs when there are 2 ureteric buds which meet the metanephric blastema to form 2 renal collecting systems in 1 kidney. And the upper pole collecting system will often insert ectopically into the bladder, leading to things like a ureterocele. but you may see hydronephrosis with the duplicated collecting system, which will be different, differentially affecting the upper and lower poles, because the upper pole will obstruct and the lower pole will reflux. We can see other cases with less degree of dilatation here in this right kidney with two collecting systems with differential dilatation, and another case with the separation here between the upper and the lower pole moieties, which when you look down in the bladder, you can see this almost yolk sac appearance of the ureterocele within the bladder, which can be seen in about half of cases of renal duplication. Now, what do we tell parents when we see dilatation of the renal collecting system prenatally? Are they going to worry what's going to happen to the baby once the baby is born? And it turns out if you look at the degree of hydronephrosis, you can break it down into mild, moderate, or severe hydronephrosis. The presence of postnatal pathology goes up with the degree of prenatal hydronephrosis. So you can tell parents whose fetus has mild hydronephrosis that the chance of there being postnatal pathology is about 11.9%. But if they have severe prenatal hydronephrosis, the chance of there being postnatal pathology is much higher, close to 90%. So how are we going to follow these fetuses once we have detected prenatal possible hydronephrosis or hydronephrosis? And the recommendations from the consensus panel when the degree of hydronephrosis is mild would be to consider a third trimester ultrasound follow-up and certainly postnatal evaluation. But when the degree of hydronephrosis is moderate or severe, you're going to recommend follow-up in 4 to 6 weeks to take a look at how the degree of dilatation is doing. If there is any oligohydramnios, suspected posterior urethral valves, or suspected renal cystic dysplasia, these are the kind of areas where you might want to consider some sort of intervention. And the reason why we want to follow these patients prenatally, because even if you have moderate hydronephrosis as seen here, at 26 weeks you come back, at 35 weeks the degree of hydronephrosis may progress. And what about if you only have mild pyelectasis? You're in the possible hydronephrosis category. Even in that particular category, if you follow these patients, even those, the hydronephrosis may progress in utero in 28 to 37% of cases. Now, what happens if you follow these over time postnatally? And in this study, they looked at mild, moderate, and severe hydronephrosis in about in many neonates, and within the first 3 months or so, what was seen prenatally was often replicated postnatally. So even in the mild cases, in 80% of time, if you scan the child at about 3 months of age, you're going to see the abnormality postnatally on ultrasound. But if you follow over time, and this follow-up was done at about 2 to 3 years after birth, the degree of persistence of the abnormality dropped off precipitously in the mild category, and even down to 25% in the moderate category. But most of the patients who had had severe hydronephrosis prenatally still had hydronephrosis at 2 to 3 years, and over half of these neonates and children required surgery. And you can break this down in another paper based on degree of hydronephrosis, just to show you that when the degree of dilatation is small, 5 to 9 millimeters, the chances that the child will be normal, stable, or improved is very high. But when the degree of hydronephrosis is severe, the likelihood of surgery increases tremendously. And in this particular study, there were several children who died. This was related to other abnormalities, not their renal pathology. Now, moving on to the fetal bladder, the abnormalities that we see on prenatal ultrasound involve the absence of the fetal bladder, in which case we're thinking of things like bladder exstrophy, or no renal function, absent renal function, no urine is being generated to distend the bladder with fluid or urine. And we'll look at cases where their fetal bladder is dilated, in which case we are thinking about posterior urethral valves, prune belly syndrome, urethral atresia, or reflux. Now, posterior urethral valves is probably the most common severe genitourinary abnormality seen exclusively in males when there is a membrane within the posterior urethra. So everything behind that membrane dilates due to the obstruction from this membrane. So you'll have a dilated posterior urethra, you'll have a dilated bladder, dilated ureters, dilated renal collecting system and hydronephrosis. And you're going to have oligohydramnios as the amount of amniotic fluid is diminished from the lack of fetal urination. And here you can see this very large bladder in a small fetus with oligohydramnios surrounding. Now here are some examples of posterior urethral valves. You can see this marked dilatation of the renal pelvis bilaterally, the dilated ureters, very, very large bladder. And here the bladder you can see with this keyhole appearance with the dilatation of the posterior urethra. As you follow this, you can see that the kidneys have a very echogenic appearance of the cortex, so you would worry about some early signs of renal cystic dysplasia. And in this particular case, now you can see at a different time that there is a ton of ascites here, and this is due to bladder rupture from the tremendous amount of pressure from the obstruction. Now, what are the prognostic indicators for posterior urethral valves? Certainly, if there's oligohydramnios, the prognosis will be worse. And if the diagnosis is made earlier, the prognosis is worse. If you begin to see signs of renal cystic dysplasia, that is a poor prognostic sign, as well as associated abnormalities or perinephric urinoma. Now, prune belly also occurs in males, and this is due to absent abdominal musculature and abnormal smooth muscle. And because of this, the bladder will dilate it. You'll see hydroureteronephrosis, just like in posterior urethral valves. But unlike posterior urethral valves, there'll be a normal amount of amniotic fluid. There'll be no urine ascites because this is a functional abnormality, not a mechanical obstruction. And as opposed to posterior urethral valves, you can look for fluid in the penile urethra. Here you can see fluid traveling all the way down the penis to the meatus, and you would never see this in valves. And this can be a very valuable finding to distinguish prune belly syndrome from posterior urethral valves. Here you can see a markedly dilated bladder, very big, hydronephrosis in the kidneys bilaterally, but notice the normal amount of amniotic fluid in this fetus with prune belly syndrome. Now, bladder exstrophy occurs when the bladder is everted through a defect within the anterior abdominal wall. It's almost like an omphalocele, but lower down. But because the bladder is everted and the mucosa is exposed to the amniotic fluid cavity, there is no bladder. You shouldn't be able to see a bladder within the pelvis, but instead you see a soft tissue mass on the surface of the lower anterior abdominal wall, representing that everted bladder. And the amount of amniotic fluid should be normal, and the kidneys will be normal as well. And you can see here is that mass. This is the bladder the bladder exstrophy. There's no bladder within the pelvis. Just to show you a normal umbilical cord insertion, because it does look somewhat like an omphalocele. And here's sort of the picture. You can see what after the baby was born, you can see what we were looking at. Here's the normal umbilical cord insertion and this bladder exstrophy. This is the bladder mucosa that you'll actually seeing, which is exposed to the amniotic fluid cavity and then air after birth. Now, one last comment I'd like to make is about ovarian cysts. These are cysts that can be seen only in female fetuses, which can be developed due to maternal or placental hormone stimulation. And you'll see these cysts separate from the bladder. They don't get bigger and smaller over time like the bladder would, representing ovarian cysts. And like ovarian cysts in adults, these may undergo torsion or hemorrhage. We could see a cyst here. There was a little bit of echogenic material laying dependently within this fetus from an ovarian cyst, and 2 weeks later, on ultrasound, you could see there was ascites and a normal ovary here. And what had happened, this cyst had actually ruptured, leading to ascites, and the cyst was no longer seen. And that is entirely possible prenatally. Now, I'm done with my talk. We've had an overview of certain findings we can see within the kidneys, including abnormalities of location, abnormalities of obstruction, dilatation. We've looked a little bit at dilated ureters and dilated and absent bladder. And always remember, when you're thinking of the genitourinary system, you need to assess the amniotic fluid volume, because that will certainly have implications for prognosis for the fetus after birth. Thank you.